Hello, can you hear me now? Can you hear me?
Yes, thank you.
Okay. Okay. Well, good morning, everybody. And thank you to all the witnesses. Thank you to my colleagues for joining today's briefing. This subcommittee on economic and consumer policy is doing everything in our power to protect the public health in these trying times. When we see problems, we step up to address them. That's what happened with antibody tests, the tests that detect if an individual has previously been exposed to COVID-19. When used properly, accurate, reliable antibody tests hold great promise. But in March, the FDA set a policy that would allow any company to sell any antibody tests whatsoever, simply if they told the FDA that they had, quote unquote, self-validated the tests. Nothing more. FDA took companies at their word. When I ask my kids to clean their room, I can tell you my wife and I don't rely on self-validation. However, that is the policy that had been adopted by FDA until recently. In essence, FDA declared that it would not regulate antibody tests. The administration attracted a lot of negative attention for its slow rollout of diagnostic testing earlier. So here, in the case of antibody tests, they swung completely in the opposite direction by allowing any test, regardless of accuracy or reliability, to go to market. This lack of oversight drew in scam artists and shysters who quickly flooded the market with hundreds of junk tests. They have been peddling hope to a public hungry for answers and an easy route back to normal activities. It opened the door for companies like VitaStick, maker of vaping devices, and Jiangsu Yubo Biotechnology, whose other offerings are male enhancement powders, cures for baldness, and steroids. It also attracted companies like Vivera, whose owner was previously sued by FDA for illegally selling untested dietary supplements. By the way, you can still buy the Vivera test because the FDA has yet to vet that test. One company claimed a positive result meant people could, quote, discontinue social distancing, quote, close quote. The subcommittee worked with that company and convinced it to mail correction letters to tens of thousands of misinformed customers. This subcommittee recognized the problem early on. We wrote to the FDA Commissioner multiple times. We had a briefing with FDA officials and CDC officials, and we ultimately issued a staff report detailing the problems with the policy, which was one of a lack of oversight. The result? The FDA listened. Within days, it changed its policy and set standards. It required manufacturers to submit their tests to FDA review and provide details on how well their tests perform. It's an example of the good that can come from congressional oversight and a responsive public health agency. The improved policy will literally save lives. As heartening as it was to see FDA improve its policy, our work is not done. Right after the policy change, 34 tests were pulled from the market, 23 of them junk tests made in China. But there are still 192 tests. Let me just repeat that. 192 tests on the market that FDA has not reviewed. FDA must complete its review quickly, recall junk tests, and ensure that people only use quality tests for the right purposes. Now, let me make this point very clear. Until the FDA pulls those tests are allowed to be sold, even if they're junk tests. The truth is, many people mistakenly view antibodies as a get out of jail free card to return to normal life, a dangerous misconception used as a selling point by bad actors. Antibody tests are not a ticket to normalcy. A lot of the tests simply don't work that well. Even tests meeting FDA's standards can be false more than half of the time, especially if the prevalence of COVID-19 in the surrounding population is low. And even with a true positive, scientists are not sure even what that means. While a prior infection likely confers some level of immunity, we don't know how much and we don't know how long it will last. People who mistakenly think that they are immune will stop taking precautions, risking infection to themselves and risking the spread of disease to others. Because of those question marks, the CDC says we can't yet use these tests for guiding individual life decisions. But bafflingly, it is still easy for someone to go and get an antibody test, and that test is unfortunately likely to be a junk test today. Today, I look forward to hearing from some of our country's most renowned experts on the subject of antibody testing, and I hope we learn more about the current status of FDA's antibody policy and what we must do to further protect American public health and safety. With that, I would like to recognize our briefers for their opening remarks. First, I'd like to start with Dr. Ehrenfeld. Dr. Ehrenfeld, you are now recognized for your opening statement.
Thank you so much. Can I just check that you can hear me?
Yes, I can hear you.
Wonderful. Well, good morning, Chairman Krishnamoorthi, Ranking Member Cloud, members of the subcommittee. My name is Dr. Jesse Ehrenfeld. I'm the immediate past chair of the American Medical Association's Board of Trustees. I'm a practicing anesthesiologist and a senior associate dean, a professor of anesthesiology, and director of the Advancing a Healthier Wisconsin Endowment here at the Medical College of Wisconsin in Milwaukee. I thank you for the opportunity to brief you today. Testing for COVID-19 has presented numerous challenges, and while the availability of diagnostic testing appears to be slowly improving, the entire testing landscape has been further complicated by the recent availability of serologic testing for COVID antibodies. Diagnostic tests can confirm if a patient has a current active SARS-CoV-2 infection, while antibody testing is designed to help us detect if an individual has had a past infection and has developed an immune response. Now, although that sounds helpful, we recognize that serology tests have a number of limitations that may result in actual harm to public health. In particular, the AMA is concerned about the possibility of COVID-19 serology tests returning false positive results, leading to individuals thinking that they may have immunity to COVID-19 when they in fact do not. Due to these limitations, the AMA has recommended against the use of these tests by individuals outside of certain settings. There are some situations in which the use of an antibody test is important and appropriate, such as for population seroprevalence studies, for evaluation of convalescent plasma donors, and as part of a medically necessary, well-defined testing plan for patients working with physicians. However, we do not recommend individuals seek out these tests without first consulting with their healthcare provider. We know that there are many that are anxious to return to normal life and discontinue physical distancing. But given that the antibody tests too often return false positive results, and we know very little about what immunity a COVID-19 infection actually confers, we currently do not recommend that antibody tests be used by individuals to make decisions about their path forward. In early May, the AMA expressed our concerns surrounding current serology testing with various arms of the administration, including the Food and Drug Administration, CDC. We also shared with them the AMA's recently issued guidelines on serology testing, which I've also shared with the committee. In late May, the CDC updated its own guidelines, bringing them in line with the AMA's guidelines. In its update, the CDC notes ongoing concerns about poor performance among many of the serology tests currently available on the market, including the significant possibility for false positive results. The AMA concurs with CDC recommendations that serology tests not be used as the basis for making policy, returning to work, or for decisions about housing or congregating groups of people. We were also pleased to see the FDA take action to require an emergency use authorization for all commercially distributed antibody tests and move to publicly post performance characteristics for those tests. Thank you very much, Chairman.
Thank you so much, Dr. Ehrenfeld. Next, I would like to recognize Dr. Goodman for her 5-minute opening statement.
Yeah,
For
that's
his
okay.
opening statement. Thank you, Dr. Goodman.
No problem. And we've got two Jessies here today, which is unusual. Welcome, Dr. Ehrenfeld, too. Good morning, Chairman Krishnamoorthi and other members. I'm Jesse Goodman. I'm a practicing infectious disease physician and professor of medicine and infectious disease at Georgetown. I was formerly chief scientist of the FDA, and in that capacity led many U.S. and global public health responses, including serving in the government leadership for the 2009 H1N1 pandemic. As such, I've had a lot of experience in this area of responding to public health emergencies and the diagnostics as well. I think Dr. Ehrenfeld began this discussion very well, and I'll try not to be duplicative, but it may be helpful to just, for general audience, to clarify the two major types of infectious disease diagnostics. And the first type detects the presence of a virus in samples, for example, for COVID-19 in the respiratory samples, and that's the nasopharyngeal swabs that everybody is getting. And in this, we detect the actual genes of the virus, and this diagnoses the presence of infection. And these tests are positive in around 80% or 4 out of 5 patients when they come in presenting with symptoms due to COVID disease. We're not talking about that here today, but those are really important. That's how you usually make the diagnosis. The second type of test doesn't detect the virus, but detects our body's responses to the virus. And typically this is done with a serology test, such as we're talking about today, that detects the person's antibodies. These are proteins in our blood that we make in response to an infection. And these tests don't usually turn positive till at least several days after infection and can be positive for many months to years afterwards. Thus, these serologic tests are not generally used for diagnosis of an infection, but they can be helpful in telling if a person's been previously infected, and as Dr. Ehrenfeld mentioned, in understanding where and how the virus has spread in the community. Now, we don't know yet how protective antibodies are against future infection and for how long, and we don't know the performance of many of these assays, but in the future, if this was proven to correlate with protection from the disease, it could help predict that a person has a much reduced risk of from future exposure. But that's not something we're ready to do now. Now, with that background, and from my perspective leading public health responses, I wanted to emphasize 2 points from this experience with serology. First is, while people tend to immediately focus on we need a vaccine, we need a treatment, how important diagnostics are from day one of a public health response. And we see what happened when efforts to develop the diagnostic test, the detection test for COVID-19, stumbled. In essence, as you've heard many times, both public health and medicine were flying blind in a storm and with no radar. We couldn't test enough people to tell where the infection was or control it. And as clinicians, we couldn't diagnose patients. And I think this had a major impact both on the pandemic spread in people's lives, and it illustrates the importance of these tests and never to rely on just one test or developer in an emergency. And more robust efforts must be made in the future to be sure we respond adequately to diagnosis, even as the disease emerges. And the government can play a major role in this endeavor. You can bring in industry and academic partners early on. You could share samples of virus and patient samples, and you make it, and as the FDA can make clear what kinds of performance qualities are important for these tests and accelerate access to these tests under their emergency use authorization or EUA provisions. And this happened very effectively in the H1N1 response, so it can be done. And this is something where Congress and the American people in the public health industry can invest more ahead of time for pandemics so we're better prepared. And then the second major point I wanted to make is, in addition to facilitating the development of tests, these events around serology illustrate the need for FDA to be fully engaged as an independent assessor of diagnostic tests. As has been said, in March, in an unprecedented action, FDA unfortunately opened the door for widespread marketing of COVID-19 serology tests by commercial manufacturers essentially without any review, regulatory framework, or control. And the chaos that ensued demonstrates why we have an FDA to ensure our medicines and diagnostics are safe. Both qualified and unqualified entities flooded the market. As you mentioned, many are now being withdrawn, Chairman, due to poor sensitivity or specificity, or both. These false negative results may convince a patient or a doctor that a person did not have coronavirus, even though they did, and false positives might lead someone to believe they're protected and behave differently. This just shouldn't have happened. While FDA was rightfully trying to accelerate access to tests, there should have been needed oversight and quality control. So thankfully now FDA is acting to correct this situation. I agree they must move quickly to assess the nearly 200 tests already out there and remove any that aren't reliable. It's also a great development that FDA and the National Cancer Institute are working together to facilitate objective evaluation of test performance.
Thank you, Dr. Goodman.
Okay.
I'm sorry. I'd usually have a gavel and be able to give you a little warning, but today I might have to jump in. Thank you for observing the shot clock, everybody. Let me now move on to Dr. Rakeman. You are now recognized for your opening statement.
Thank you. Good morning, Chairman Krishnamoorthi, Ranking Member Cloud, and members of the subcommittee. I am Dr. Jennifer Rakeman. I'm the Assistant Commissioner and Laboratory Director of the New York City Public Health Laboratory at the Department of Health and Mental Hygiene in New York. On behalf of Mayor Bill de Blasio and Health Commissioner Dr. Axios Barbeau, thank you for the opportunity to testify today. The New York City Public Health Lab, or PHL, has been central to New York City's response to the COVID-19 pandemic. Before testing capacity was available at clinical laboratories across the city, PHL provided critical testing capacity for all hospitalized patients in New York City suspected to have COVID-19, including patients at the city's network of public hospitals, H+H. With more testing capacity now available citywide, PHL has pivoted to support other critical aspects of the response, including providing testing for people in higher risk settings, such as homeless shelters and other congregate settings. I want to start with some basics about the virus and antibodies. COVID-19 is the disease caused by SARS-CoV-2, and when infected with this virus, the body mounts an immune response and produces antibodies. SARS-CoV-2 serology tests detect the presence of these antibodies, but cannot be used to diagnose acute infection. Further, serology tests for COVID-19 cannot, at this time, tell us whether someone has SARS-CoV-2, tell us whether someone with these antibodies is immune to infection. We don't know yet if having antibodies means that a person is no longer shedding infectious virus and therefore unable to infect others, nor how long the antibodies will remain. Serology tests can be designed to test for different classes of antibodies. Some test for IgM antibodies, which develop early in infection. Others test for IgG antibodies, which are more likely to show up later after the person has recovered, and others test for both. Thus, the duration of time since a person was infected with the virus and the type of test to use will impact whether antibodies may be detected. Understanding both the specificity of the test, or does it detect antibodies specifically to this virus, SARS-CoV-2, as well as the sensitivity of the test, or how often the test will detect a known positive, are critical to interpreting results. For example, tests that have low specificity may produce a false positive test result reflecting an infection with a different human coronavirus, which normally circulate in our population. Serology tests that are both sensitive and specific can play a role in providing population-level estimates of the prevalence of past infection. We know little about the significance of an antibody response to the virus, and therefore these tests have limited clinical significance at the individual level and should not be used to make decisions about returning to work or physical distancing or other things like the use of face coverings or other disease prevention measures. We do not know whether SARS-CoV-2 antibodies confer durable immunity from further infection, that is, whether someone can be reinfected and get COVID-19 again. And while there are some promising studies that show some level of immunity, we don't know how long it will last. Messaging this to policyholders, policymakers, providers, and the public is critical to ensuring that decisions about whether and how much to relax restrictions are made with an understanding of potential health risks. The New York City Department of Health has issued guidance to health providers and the public regarding the meaning of these tests and what they do and do not tell us. This month, the New York City Health Department launched a serosurvey as part of a population-based COVID-19 cross-sectional survey. The serology testing for this study will be performed at PHL on specimens collected from respondents in their homes. The data from this sero survey will be able to help us better estimate the overall infection rate in New York City and better estimate overall hospitalization and case fatality rates. Let's pivot quickly to what happened in the US with serology tests. As noted on March 25th, the FDA issued guidance allowing the development and market distribution of serology tests as long as test reports included a number of disclaimers. The policy allowed more than 200 serology tests that were not evaluated by the FDA onto the market, many of which were of poor quality. A list of these tests was published on the FDA website, and many companies aggressively and unscrupulously marketed their tests as FDA authorized or marketed them as point-of-care tests that could be performed outside the laboratory setting. Immediately, public health laboratory directors from around the country began pushing for the FDA policy to be revised or better reversed. We sent letters from the health department out to providers about this. On May 4th, the FDA revised its policy to require all manufacturers to apply for EUA within 10 days or stop selling their tests. Of all of the 200 tests that were already on the market should have had an EUA submitted by May 18th or be pulled, but to date, only 34 tests have been pulled. It is unclear whether the EUA applications have been filed for the rest, and it is concerning that the tests continue to be available while under review by the FDA. Enforcement is unclear. Even though the FDA has said these tests are not authorized, their presence is still an issue and gives these tests credibility. This policy needs to be reviewed and scrutinized before the next emergency so we can balance the need for available tests with the need for accurate tests. Before closing, I want to zoom out and take a moment to reflect on the loss of lives and livelihoods that have occurred during this pandemic. These losses have not been sustained equitably, and we need to acknowledge and address the institutionalized racism and health disparities that have enabled these inequities to exist. Addressing serology testing is critical, but is a small piece of much larger work ahead. Thank you once again for inviting me to testify today, and thank you for your continuing advocacy and support in funding state and local public health departments for COVID-19 responses. I look forward to your questions. Thank you.
Thank you, Dr. Rakeman. Now I'd like to recognize Dr. Gronval for your 5-minute opening statement.
Thank you. Good morning, Chairman Krishnamoorthi and members of the committee, and thank you for the opportunity to be part of this briefing. My name is Yuji Gronval, and I'm a senior scholar at the Johns Hopkins Center for Health Security, which is part of the Bloomberg School of Public Health. Our center aims to develop policies to protect people's health from epidemics and disasters and to promote community resilience. My background is in the biological sciences and immunology. Important for this briefing, I lead our center's efforts to track COVID-19 antibody and molecular tests. We have an updated tracker on our website of all the tests that have FDA emergency use authorization and their accuracy levels. We previously published a report on COVID antibody testing uses and limitations, and later this week, we are releasing another report to describe how antibody tests should be used in larger studies called sero surveys to get the most information for public health decision making. So in the course of this work, we've developed some findings about antibody tests that I'd like to share. First, antibody tests are useful for public health. Using these tests for sero surveys, the true case fatality rate of COVID-19 can be determined. Sound decisions can be made about PPE resource allocation, mitigation efforts, and ultimately, we hope, vaccine procurement and prioritization. Second, there are significant uncertainties about what antibody test results mean, as has been described, which limits their usefulness to individuals. It doesn't appear that reinfections are occurring, which is wonderful. So for now, it seems that people who have had the disease are protected, but we don't know what the correlates of immunity are. We don't know how long immunity is going to last, and we don't know whether it's going to be important to have a certain level of antibodies to be protected. Third, as you're well aware and why this is happening, the quality of antibody tests in the US have been highly variable, making results difficult to interpret. Our fourth finding relates to relying on antibody tests to support back to work decisions or for immunity passports and how that is problematic. It's problematic for several reasons. Seroprevalence is now quite low, so if only COVID-19 positive people are allowed to work, most people are not going to be working. It's not clear how long immunity is going to last. The testing could be inaccurate, and requiring immunity for employment could create perverse incentives, leading some people to try to get COVID disease. So given these findings, we have several recommendations for the US government to act upon. First, the quality of antibody tests should be clear to purchasers. And so independent validation study results from the NCI that are being undertaken right now should be clearly marked and made prominent on their website and should be available to purchasers. The second recommendation is that the CDC should coordinate the serosurveys across states and public health departments and develop a common protocol for states to use. All jurisdictions are facing similar challenges trying to inform policy and mitigation strategies for COVID, but they've been designing and initiating their own studies. National coordination would provide more information and it would be more efficient and decrease costs. Third, the US government should create a central repository for serosurveys similar to clinicaltrials.gov. Most serosurveys studies are announced when they're done, which prevents shared learning and coordination. Fourth, large employers and universities who are using antibody tests should also register their studies in a central repository, and the CDC should give them specific guidance on what should and should not be interpreted from the results of these studies. In conclusion, we need to think about antibody tests long term. Lingering medical issues from COVID will require accurate tests. Past infections could be the source of employment discrimination in the future. COVID recovery could change vaccine prioritization, or it could lead to one vaccine candidate being a better fit over another. Vaccination and/or a positive serology test may eventually be required for travel. So we need to think about how antibody tests are going to be used in the future. Thank you to the committee for including me in this briefing, and thank you for your leadership in guarding against fraud in antibody testing.
Thank you so much, Dr. Granval. Now we're going to move to the Q&A portion of the briefing. As a reminder, each member will have 5 minutes to allow enough time for all members to ask questions. Once recognized, please wait for confirmation that you have been unmuted before asking your question. I now recognize myself for questioning. Dr. Goodman, first question is to you. The new policy requires all companies to apply for emergency use authorization, otherwise known as EUA. You know the EUA process well from your time at FDA. Is there a set timeline for ruling on any individual application?
Thank you for that question, Chairman. There are not, as for routine FDA products and processes, specific set timelines for acting on emergency use authorizations. However, part of the flexibility there is the intent that they can be acted on extremely quickly if they meet the known criteria and the needed information is there. So many times during an emergency, we turn these around within 24 hours. Now, a concern, yeah, go ahead.
But how about, in this case, we have 192 applications.
Yeah, right.
Is the FDA used to reviewing that many applications at once?
No, this is an extraordinary situation, and it obviously shouldn't be repeated. But I think these are not complicated authorizations to review, and FDA has now laid out criteria that they are requiring for performance. So I think this could be done very quickly by the right teams of people at the agency.
But let me ask you this. Let's say you have a bad actor who makes junk tests, okay? They obviously were initially drawn into an unregulated market. Is there anything stopping them from submitting an EUA to grab a few more months or more of profits and the ability to sell to unsuspecting consumers until the FDA reviews their application?
Well, I think unfortunately it has opened the door for the continued sales of these devices. But what I would say is that, again, FDA has stated that these EUAs should be submitted within 10 days, 10 working days. So FDA should have those. And if they don't have those, they can shut those manufacturers down. And if they do have them, they can certainly prioritize review of applications that they see as high risk. And I think they need to do that.
Now, let me direct this. Actually, let me just ask one follow-up question to Dr. Goodman. But just to be clear, if you were manufacturing a junk test, you're a scam artist or a shyster, there's nothing, no incentive for you not to go ahead and submit your EUA within those 10 days to be able to continue selling to unsuspecting consumers, right?
Right, but once you've submitted that, you start FDA reviewing it, and I believe in my heart that they are not going to allow those kind of tests to be out there for long. But having an efficient, rapid process that does that is critical.
Dr. Rakeman, let me ask you this. With suspect and potentially faulty tests on the market, do you think the FDA should allow these tests to be sold while applications are pending?
I think that is a problem, and we have seen that there have been some of these test makers really unscrupulously marketing those tests directly to physicians' offices. Even yesterday, I got several emails, some from my partner agencies who had gotten emails directly from companies marketing these tests, and some directly to me marketing tests as FDA authorized, even though they're not FDA authorized. And so I think that there needs to either be some very swift action and good resources to FDA to be able to turn these around very, very quickly, and or that these tests should not be marketed until they have the EUA.
Dr. Ehrenfeld, what do you think? Do you think that these suspect or junk tests, in light of the number of them, should continue to be sold pending FDA review?
Well, I do think there is an additional action that the FDA could take on this issue, and I'd like to throw it out because it hasn't been raised. You know, the FDA has provided 2 fact sheets for distribution with these tests, and one is geared towards patients, one is geared towards providers. I think it would be really helpful, and we would fully support providing the CDC's warnings regarding the use of these tests as a part of those fact sheets that are distributed across the country.
Very good. Dr. Gronvall, what do you think? Do you think that we should shut down the sales of these tests pending the applications at the FDA?
I think that there's such a great personal demand for these tests, in spite of all of the caveats that have been on the news. That you can't necessarily trust the results. So people are making decisions based on these tests, which are faulty, and so I think that's a problem. So whatever can be done at the FDA to stop that, I think is really worthwhile.
Very good. Let me now move on to my colleagues. I'd like to now recognize Congresswoman Presley for her 5 minutes of questions. And Amy will unmute Congresswoman Presley. Please begin.
Congresswoman Presley, you have been unmuted. Please proceed with your questions.
Thank you, Mr. Chairman, for convening the subcommittee today to discuss this important topic. Our nation is in the midst of a crisis within a crisis. The righteous outrage that has driven thousands upon thousands to our streets in protest to the systemic racism and inequity in our nation's policing system has also added to the trauma that our communities, particularly Black and Brown folks, are experiencing as a result of this ongoing pandemic. My district, the Massachusetts 7th, has been one of the hardest hit throughout the Commonwealth. Millions in America continue to be out of work. Families continue to struggle between paying their rent and keeping food on the table. Our small Black and Brown owned businesses continue to struggle. But it is so important that we continue to stress that our greatest wealth as a nation is the health of our people. And the health of our people must be our #1 priority. In typical fashion, this administration has ignored guidance from medical experts and even suggested using individual antibody testing as part of a plan to reopen the economy, despite an estimated 51% chance of false positives. 51%. 51% of folks who could have been under the false assumption that they are safe from further infection and might make the decision to ease back on physical distancing. The truth is, antibody testing cannot and should not be indicators for reopening, but they can help us to monitor trends when used for population-level data gathering. Dr. Gronvall, how are the tests best used for research and informing future public health and policy decisions, including where to allocate resources?
Yes, thank you. You mentioned the most important thing, that the public health authorities should be in possession of these tests and good tests to be able to do these large studies to find out the prevalence of disease and the incidence, how disease trends are changing over time, and whether public health mitigation efforts are succeeding. So that is the most important priority, and the CDC should be overseeing those tests and coordinating so that we can get the most value, not only right now, but in decades from now, when we're trying to see how how people their lingering medical effects, if they have any, and to trace that back to today's events.
Thank you. You have also intentionally designed your study to include all communities, including Indigenous communities, Black and Brown communities, again, which have disproportionately bore the brunt of this pandemic. The data that we do have has shown the COVID-19 mortality rate is nearly 3 times higher for Black Americans than for white Americans. And we know the numbers are likely even higher than that. Dr. Reichman, as we get better data from studies like yours, how would help us to better understand the total impact on communities?
Thank you for your question. So we know that, as you said, different communities have been very differently impacted by this disease. One of the things that makes it difficult to look at those numbers is that we also know that diagnostic testing, especially early on in the pandemic, was not equitably available across all communities. So doing a population-based seroprevalence study allows us to look at a representative group of people who represent the population of a given jurisdiction, in our case, New York City, that will let us know where infections had occurred, where infection rates were higher or lower or different, and it allows us then to get a better understanding of the true rates of hospitalization and death. So New York City is always driven by equity. It's part of every single thing that we do as an agency, and our seroprevalence population-based study is part of that, and will help drive where resources go going forward to ensure that communities get what they need.
Thank you. I yield.
Thank you so much. Thank you so much, Congresswoman Presley. I now recognize Congresswoman Tlaib. You have 5 minutes.
Thank you so much, Chairman, and thank you all so much for taking the time to be here with us on this important issue. My district, 13th Congressional District, I lovingly call 13 District Strong. About 30% of my residents work in the automotive industry. And as you know, they're transitioning a lot of those folks, which can be hundreds in one facility all at once. And so there's a huge fear about what the process is on the ground. So as you all know, on May 23rd, the CDC issued guidelines clearly stating the antibody test, quote, should not be used to make decisions about returning persons to the workplace. CDC also said not to use the test when deciding to return to, quote, congregate settings such as schools, dormitories, and correctional facilities. So Dr. Grunwald, do you agree with the CDC on these points?
Yes, I think that I've heard occupational safety experts have described using these tests in ways to group people together so that workers who have been exposed can maybe be a shield next to people who are still vulnerable. And there are some creative ways to think about that. I just would like to know when employers are doing kinds of surveys like this, why they're doing them, and to have more insight into their data so that they aren't used for any discriminatory reasons.
Thank you, Dr. Feld. What do you think can we do as a body to prevent us from using antibody tests for these purposes?
Well, I think there's a lot of confusion, and again, we were delighted that the CDC updated their guidelines, as you noted, to become, I think, more appropriate. They're in line with what the AMA is recommending. One of the hard issues is diagnostic testing has not scaled the way that we probably still needed to. I live here in Wisconsin. We've got 62 labs. We can do 16,000 tests a day. We're expecting 150,000 students that are going to be back on campuses in the fall. It would take us 4 weeks to test every student once. let alone all the employers and manufacturers and other facilities. They're trying to sort of navigate what to do. So again, an action that I already mentioned that I think would be really helpful would be for the FDA to put out in the information that's being provided to patients and providers the limitations on serology, because we simply do not believe that individual level decisions should be made on the basis of an antibody test today. And yet we know that there's confusion and that people really want to do that.
And, Dr. Grunwald, to get back to you, I mean, I see ethical reasons not to use the antibody testing specifically because of what we've seen, companies selling poor performing tests and looking for buyers. And we expect a lot of businesses to take them on it. And so despite even the CDC guidelines, I mean, what can you be very clear? Like, what are some of the ethical reasons that these businesses should be aware of before they proceed to use this as a way to get people back to work? I think you're muted. There you go.
There aren't enough people who have recovered to really make it possible to have everybody only come back to work if they've been exposed. And you don't want to incentivize people getting disease. But also, I worry about the future when people, right now everybody wants antibodies, but there might be a time when people don't. And the Department of Defense is apparently considering a policy where they will not recruit people who have had COVID disease. So it could, that could become a trend further on because there might be lingering health effects and with higher costs. So it's just something to consider for the future.
And despite the clear CDC guidelines, when my staff shared this information with me, told me about how Quest and LabCorp, the country's two largest lab testing companies right now, have both offered the comprehensive testing services, including the antibody test, to businesses to test their employees. One tech startup called Because Health is selling, quote, workplace health plan at $350 per person to determine exposure to COVID. Its medical director was quoted saying, "There's a tremendous consumer demand. Can they return to work? Can they return to life?" So, Dr. Grunwald, can this test really truly be used to determine whether employees should return to work, yes or no?
No, it cannot.
I know this. If employers had access to antibody tests, how can they be used to, you talked about discrimination, and that's something that's very concerning to various folks in my community that do worker rights issues. I know the Department of Defense may not allow anyone to enlist who has COVID right now. Did you know that?
Yes, so that's apparently something that they're considering, and I'm sure that the budgets are involved with that.
So just, for everybody to know, without clear guidance from CDC, employers are now eager to open and looking for low-cost solutions. That's why we're having this hearing. And we're also feeling very much that they're done in an inappropriate way, coerce employees to return to unsafe working environments. So I just know policymakers at HHS need to know that many members of this committee and others, we're asking you to ensure that companies do not use this testing tools just for their bottom line. So again, thank you so much to Chairman for this important hearing. Many of my auto workers are, very, very fearful as we approach. So many supply chain logistics industries are also doing the same. So we do appreciate this hearing. And I yield.
Thank you. Thank you, Congresswoman Tlaib. I had Congressman Connolly. Is he still with us? Maybe he had to step out. So we're going to go to Congressman Sarbanes. Congressman Sarbanes, you are recognized for 5 minutes.
Thank you, Mr. Chairman, and thanks to the witnesses today. Actually, many of the questions I was going to ask have already been asked, but maybe I can flip this a little bit because a lot of the discussion appropriately has been on why we need to be cautious about the antibody test and where we cannot rely on it, both in the sense of there not yet being a sufficient level of testing where there's high percentage of reliability based on that test. And we've talked about how we think the FDA came out of the gate too fast in some of these approvals and so forth. But maybe the witnesses could respond this way. where do you see the best deployment of antibody testing as we move forward? Obviously, the desire to reopen the economy, to get back to whatever normalcy there can be or a new normal, has invited discussion of the ways we can deploy these serology tests. And I know different political leaders and public health experts are kind of weighing when you would put the antibody test into the equation in the most constructive way possible. So let's assume two scenarios. One, the reliability of the tests available to us kind of stays where it is in terms of false positive, false negative. If that's the case, where can you actually use the antibody testing in a constructive, useful fashion? And or do you need to get to a certain percentage reliability before you would be comfortable deploying it in any scenario? So I'm trying to talk to me about the positive opportunities around it, since we spent a fair amount of time flagging the issues and challenges that are presented by it. And why don't we go first to Dr. Ehrenfeld, and then Dr. Gronval, and then Dr. Goodman.
Thank you so much for that question. So the AMA is recommending that this simply be used in 3 circumstances for seroprevalence studies that we've heard a lot about today, understanding who might be a candidate to donate convalescent plasma, and then in the limited setting of a well-defined testing plan as defined by a physician, not a medical spa, not a retail pharmacy, not to make individual decisions. You mentioned that there are issues with the sensitivity and specificity of the test. It really depends on the use case. So think about chickenpox, right? Who's had chickenpox here? Probably a lot of us, or the varicella vaccine. The antibody test for seropositivity for, varicella zoster, which causes chickenpox, is like 74%. And so that's why we don't do widespread antibody testing to see who's had chickenpox, who's immune. But there are circumstances where doing that test can be helpful. The diagnostic test has a relatively small window of positivity. If you're 8-9 days out from having an infection and symptoms, there may not be a positive on the diagnostic test. There could be a role for using seropositivity to make treatment decisions, make a diagnostic decision, but those are relatively specific, unique circumstances, not the kind of mass consumer demand that we're seeing.
Okay. Others?
I would say, two things. One, it's critical, as has been stated, to get the bad tests out of there, but some of the good ones now are performing quite well. So they can be used, as Dr. Gronval had suggested, and as my co-panelists are doing, to track the disease in populations, to understand its impacts on diverse populations, et cetera. So there are the EUA authorized tests out there that can be used usefully in public health, but not, as just has been stated, usually in individual decision making. In terms of your looking at the positive side of the coin, if data evolves that shows that certain levels and types of antibody are protective against future infection, and we understand that that protection is firm and lasts a considerable amount of time, and those are big ifs. But if we get there, this may be helpful in making certain individualized decisions ultimately. But that's going to take time to get there, and people need to realize we're not there now. There is also a way of dealing with some of the false positives, which is using an independent second assay called orthogonal testing. So and we used to see that similar to that in HIV testing, where there was the preliminary result, and then there was a second test used to make sure that was absolutely correct. So there are ways to address some of these issues.
Okay, I think I may have run out of time. Dr. Gronval, if you had any last observations before I yield back.
No, public health is the main reason that they need to have these tests, and my colleagues echoed that. Thank you.
So bottom line, I guess, is very important, certainly as a data point and a data source, but not something that people should decide makes them Superman or Superwoman as they move around. thank you, Mr. Chairman, for the opportunity to weigh in today.
Hey, thank you so much, Congressman Sarbanes. Now I'd like to recognize Congresswoman Porter for 5 minutes of questions. You are recognized.
Thank you so much. Good morning, everybody. So let's imagine for the next few minutes that I am a frontline worker in a grocery store in Orange County, and I was sick in March, and I think it definitely might have been COVID-19, and I want to get an antibody test now to see if I'm immune. Unrealistically, I have spare time from my low-wage job and raising my family to do research on antibody tests. Also unrealistically, I wade through all the advertisements and noise to find the official government agency in charge, the FDA. And on the FDA's site, there is a list of antibody tests that have emergency use authorizations, which sounds to me like some kind of gold seal of good housekeeping approval. But there's a lot of these tests listed, and I want to make sure I really don't have it. Which one should, so Dr. Ehrenfeld, which of these tests has the FDA approved as scientifically sound for telling me if I have antibodies in my system?
Well, let me answer that a different way. That frontline worker.
Actually, excuse me, I'd actually like you to ask it the way I asked it. Which of the 13 tests have been, as the FDA approved as scientifically sound for telling me if I have antibodies in my system?
So I can't comment on the performance of a specific test without looking at it, but I wouldn't tell any patient anywhere to go out and get an antibody test to make decisions about stopping physical distancing or going back to work or changing behaviors.
I understand, Dr. Ehrenfeld. I heard you say that earlier. Let me try to make this easier. Has the FDA approved any of these tests? Yes or no?
I think you're asking that they have not independently validated any of these tests.
Okay, so the FDA has not done research to find out if these tests actually work and which ones work better than others.
Correct. They're relying on the manufacturer's submission.
So what use then is that list to me? Would it be just like equally, I have a really nice spinner here. Would it be equally useful for me just to spin this wheel and I can just see where it lands? I mean, Euroimmune, that sounds pretty good to me. I mean, Europeans, a lot of immunity there. I mean, Roche, that's a Siemens, they make phones. Is that a good test for me? Is there any more valid way for me to do this than spinning the wheel of scientific immunity?
I think the answer is no.
So should I market these for people? Like, this is something they could use to determine what is the best test to go get? How are people supposed to be able to choose what test is valid or understand the results that they're getting or know if this test is a valid use of their money and time if the FDA has done nothing?
Well, at this point, we wouldn't recommend that individuals pay for these tests for the purpose that you're describing.
Are you thinking someone's going to do them for them for free? Because I haven't had a lot of free healthcare in the United States recently, just speaking personally. I did get a COVID-19 test, and despite my exchange with Dr. Redfield, did get a bill for $200+ for the doctor's visit associated with that COVID-19 test. So it sounds to me like that not only do we not have any idea what test is valid, we don't have any idea what these tests tell us. So my next question for you is, do you know, and I appreciate your help here today, do you know the amount of antibodies that I would need to have to be immune?
Absolutely not. That is an open scientific question, and one of the reasons that we don't recommend individuals use these tests to make individual decisions.
Okay, so are these tests, you said that there's not a medical necessity for an individual like me, someone who thinks they may have had COVID-19 and is worried about whether I can safely go back to work or interact. You said that you would not recommend it for me. So then my question, let's move to Dr. Rakeman. If there's no medical need for an individual to get an antibody test, will my insurance cover it? Because I've just heard these tests are not medically necessary, even though they're on the FDA website.
So I can't speak for Orange County, but in New York State, there is a clause to cover tests for all patients for both antibody and diagnostic testing, despite the fact that, as you said, the antibody test has no relevance to an individual and should not drive what you do as a person.
Are Medicare and Medicaid reimbursing these unnecessary antibody tests? I mean, are we wasting taxpayer dollars at either the state or federal level paying for tests that have no medical purpose for an individual?
So again, in New York State, things are handled a little bit differently, but also these are not useful at the individual level.
Thank you so much. I yield back.
Thank you so much, Congresswoman Porter. I would like to get one of those spinning wheels if possible. If you can make one for me. Thank you. Yes, that one. Is Congressman Connolly with us? I don't see him. So I think at this point we're going to close the hearing. And move to adjourn. Let me begin by thanking all the witnesses for coming in today, or I should say, staying where you are today, and allowing us to see your lovely residences and places of work. And thank you to my colleagues for also joining. Folks, this is an incredibly important subject. All of you know this already. The demand for these antibody tests is sky high. And we estimate that millions of people have already purchased these antibody tests. And what we've learned is that because the FDA had a Wild West policy of allowing bad actors and bad products to flood the market with junk tests, millions of people literally could have taken tests that gave them very faulty results, and millions of people may have started to make or made dangerous life decisions based on them. Now, the FDA has altered course and adopted a policy of review, but as we heard, even in this situation, faulty tests are allowed to be sold pending review, which makes no sense. That being said, we counsel everybody who is watching this hearing to go to the FDA website and to review those tests that have received emergency use authorization, and only consider taking those tests, but only subject to the direction of medical professionals or public health officials, and not to use those tests for personal life decisions. That's very important. These tests hold great promise, potentially for helping to map the spread of the disease, to assess other potential markers or characteristics or traits regarding where we are in the spread of COVID-19, but cannot be used for life decisions right now. And so please be aware of what you can and can't do with these tests. And we will continue to monitor the spread of these tests, just as we continue to monitor the spread of the disease. Thank you all for what you're doing every day. And for right now, this committee is adjourned. Thank you.